Welcome to Assessment and Screening for Co-Occurring Disorders, brought to you by allceus.com. Whenever you're beginning to screen someone or conduct an assessment, one of the first things that you're going to want to do is engage that person. That seems like something we wouldn't have to talk about, but it is important, and too often we get caught in the rhythm of having to produce billable hours, and people become more like numbers to us than actual human beings. And you're not going to be able to conduct an effective assessment if you're running an assembly line. First thing you need to do is remember that every person that comes through your door is going to be different and have different presenting problems. Likewise, co-occurring disorders, that is mental health and substance use disorders, are the rule, not the exception. So it's vitally important that we don't turn somebody away from services because they have a disorder that we don't usually treat. For example, if you're a mental health person and you don't usually treat addictions, just because somebody has an addiction, don't turn them away. Likewise, if somebody presents at an addiction facility, we can't be turning them away because they have a mental health problem. We have to recognize these as equally important and inseparable disorders. Therefore, it's important to be empathic. These people our clients have probably met with a lot of resistance, and it's taken them a ton of courage and a ton of effort to get into our office. And it's up to us to recognize them as unique individuals and conduct a person-centered assessment. It's not about billable hours or cost centers. It's about John and what makes John unique, what's worked for John and what hasn't worked for John. Because even though John and Tom may have very similar case histories and very similar problems, the same thing may not work for John that worked for Tom. This is a person-centered assessment. We don't just lump people in together. Finally, we need to be sensitive to people's culture and trauma. Culturally, nonverbals can differ, and it's important not to interpret someone's nonverbals or lack of forthcomingness, if that's a word, as resistance when it may be culturally prescribed. Elderly patients were raised in a generation where you don't air your dirty laundry to perfect strangers. You don't admit weakness. There's a lot of things that you don't say that are often said in clinical assessments. Be prepared and be aware that what they're not telling you may be just as important as what they are telling you. Also, don't press. If you press them beyond what is comfortable for them, what is culturally appropriate, they're probably going to become defensive or reserved, or they may leave treatment. Likewise, if they have a history of trauma, it will be important to address the fact that there is a history of trauma, but you don't want to go into deep details. You don't want to elicit feelings surrounding the trauma because you might precipitate a crisis event. The no wrong door policy means that people with co-occurring disorders can enter the system at any point. They can enter through a case manager, through a mental health counselor, through an addictions counselor, through a detox unit, or through the legal system. Those are the 5 most common ways a person enters the system. It also may be through Department of Children and Families. I guess there's a 6th way. People with co-occurring disorders have a high priority for engagement in treatment because they are at great risk of falling through the cracks. These are people who do not do well in unidimensional treatment facilities, that is, facilities that only treat mental health or only treat addictions. Thankfully, we're getting away from that type of facility because we've recognized that co-occurring disorders are the rule, not the exception. We have to be competent and comfortable in diagnosing and addressing mental health and substance use disorders. Now, you may have two different therapists on a multidisciplinary team working with each issue, depending on what your state licensure codes are and all that stuff. But each therapist needs to understand what the other one is doing and why, and work collaboratively on a unifying treatment plan. Furthermore, it's vital to ensure that one diagnosis is not inhibiting progress on the other diagnosis. If you have someone who's doing pretty well in their addictions treatment, but their medications aren't right and they start having command hallucinations, you're going to have a problem, and that will need to be addressed. And both problems will probably wax and wane. It's typical that they wax and wane in their importance as far as treatment goes. Thankfully, most of the time, both disorders won't go all screwy all at once. You'll have one that starts to kind of veer off course, and if you can bring that one back in, it's a lot easier than waiting until everything kind of goes off track. Let's start with screening. Now, in my little more than a decade of experience in community mental health, I can honestly say that most people I've encountered tell me that their organization doesn't separate screening and assessment. There's just not the luxury of doing that. There are several reasons for that. Number one, it's hard to get people back. And once you have them there, you want to get them assessed, unfortunately for the billable hour. But also because if you can engage them early on, there's a greater chance that they will return for treatment and actually get help. But we'll pretend that screening is a separate and distinct entity from assessment. Screening doesn't necessarily diagnose a problem. It simply indicates a need for further investigation. Further, it establishes cutoff scores. So your agency will have certain tools they use and certain cutoff scores or criteria used in order to pretty systematically establish who's referred for assessment, who's referred for detox, who's referred for crisis stabilization, etc. The screening also defines what takes place if a client scores within the positive range of your cutoff scores. This could be anything from a simple referral for assessment to referral for assessment, referral for case management, referral for vocational services. There may be a lot of things that this person is referred for, and referral for medication or observation or diagnosis by a psychiatrist. In the screening, it's important to document all of these things. That way, you can go back later and say, yeah, when this person came in, we identified there was a problem, and we made all of these appointments and took all of these steps. That way you can't go back later and go, oh, oops, I figured the assessment person would pick up on that and refer for medical management or what have you. So the screening process should set forth the documentation trail. During the screening process, many clients presenting for substance abuse treatment are unable or unwilling to report past or present circumstances accurately. And this is a challenge for people in voluntary settings or for people in mental health settings, because we typically are trained to take people at face value. Yet, if somebody's being referred for substance abuse treatment, and you've got a pretty good idea that they're using, but they're not telling you, It's hard to make an accurate diagnosis of the severity of what's going on. If you're working in a drug court, if you're working in some sort of situation where you have access to objective findings, examples include the Department of Children and Families case report, criminal history records, anything that you can legally get your hands on because of confidentiality and HIPAA and all that, any concrete evidence that you can have to support any confrontation will be helpful for you. Additionally, there are tools that you can use like the SASE, which help identify a person who has a problem without actually having to come out and be confrontational. When a client is abusing substances actively, for example, shows up for the assessment or the screening under the influence, it's important to consider their risk for suicide, homicide, or just personal reckless endangerment. If you observe guardedness on the part of the client, you should also ask about trauma and ask about personal safety. Maybe the person's in a domestically violent relationship. They're afraid to be there. Maybe they have been abused before. There are a lot of things that could be going on. Nevertheless, this is when that person-centered assessment and screening comes into play. You can't just assume every client who comes through your door is going to be the same way, and you can't assume they're going to tell you the truth or tell you the whole truth. You may need to ask specific questions about a history of trauma, a current status for suicidal ideation, and current substance use and abuse. When you're asking about the substance use and or abuse, it's important to be careful how you phrase things so as not to sound accusatory or condescending or judgmental about someone's use. When you screen for traumatic past events, ask if they've had traumas in their past, but don't go into extreme details. That can be left for treatment. When screening primarily for substance use, you want to ask about past and present substance use, substance abuse, and substance-related problems. For a lot of clients in pre-contemplation, they will have difficulty linking their substance use with their biopsychosocial problems. So this is a good time to step in with some motivational interviewing and help them identify how the substances are affecting their relationships, what their wife thinks about it, what their mother thinks about it, how it's impacted their finances and their work product and their general health and happiness. You can use all these things to motivate the client to engage in treatment. It's also helpful to provide people with substance abuse symptom checklists. Depending on your client's level of education, you may need to read through these checklists with them. You can do this in a couple of different ways. If you have a group full of people that are going through the screening, and each of them has in front of them a paper that lists the substance and associated symptoms, they can go through and mark it off. You can read each drug and each associated symptom, and people can mark it off en masse. They don't have to say anything that would breach their confidentiality. Make sure you have a block on each one to check for none. That way people aren't put on the spot when you say cocaine and withdrawal symptoms and they mark it, that it becomes obvious to everyone in the room that they have cocaine withdrawal symptoms. If you're careful and you do it right, you can do checklists within a group environment, which does expedite the screening process, especially in probation and parole and other situations where you have to process a whole lot of people really fast. You want to screen for the presence of substance abuse symptoms and problems using formal screening tools as well as drug testing. Now, it would be nice to think that we could use hair samples and saliva and have blood tests and everything at our disposal, but that just doesn't happen. Therefore, it's vitally important that you are able to accurately collect a urine sample. And that means, unfortunately, watching the person pee in most cases, making sure they don't have bleach on their hands. There are a myriad of ways to defeat a urine test. And if you don't get a positive report or a correct report, then you're not going to be able to effectively use that in your treatment planning. During assessment, you want to look at suicide potential and level of lethality, how behavioral, emotional, or cognitive conditions interfere with addiction recovery efforts, social functioning, and how those mental health issues have impacted the course of their substance abuse, and vice versa, how their substance abuse has impacted the course of their mental health illness, because they're not completely separate. A person who has bipolar disorder may see a gross exaggeration of their symptoms while they are using or abusing substances, and it may expedite the decompensation of that person. Likewise, a person who abuses substances may tend to abuse more or use different substances when they're in the throes of a manic episode or a depressive episode. The comprehensive assessment comes next. You've screened, you've established the fact that there are indicators that this person has a problem and they need to go for a more thorough assessment. Wonderful. But what do you do in a comprehensive assessment? Depending on your agency, you may have more or less wiggle room in what you ask about because they have more or less structured forms. I've provided a general form on the notes of this slide that will give you an idea of some key things that you can ask. But an assessment is designed to accurately identify those who need treatment. The DSM-IV diagnoses really look at what's going on with the person. It permits the evaluator to learn more about the nature, correlates, and consequences of the substance-using behavior. So what does that mean? The nature of the behavior. What do they use? Why did they use it? When did they use it? Correlates. Are there certain things that precipitate use? For example, the people they hang out with, or is it always on Friday evening? And consequences. Well, that's pretty self-explanatory. What's gone wrong since you started using? But what we forget to ask is what has gone right. And a lot of you are sitting there going, what? But it's true. We do not do things unless there's a benefit. So what are the positive and negative consequences of the substance-using behavior? Most likely it gives them an escape, makes them feel better, gives them a break. This is where we can start with helping them identify pro-social ways, healthy ways, to handle whatever precipitated the substance use. This is also a good time to identify any supports the person may have. A person in treatment, in residential treatment, isn't at as high of a risk as a person in outpatient treatment who has no social supports. But eventually that person's going to be discharged into outpatient treatment. And everybody needs social supports. Nobody can do it on their own. It's not realistic. So this is the time to identify if the person has any sober social supports that can be involved in the process. We know from research, family therapy theory, that if the significant others are not involved in the treatment process, they are not going to be much use when the person's discharged 30, 60, or 90 days from now, because the person will have changed, but the family system will not have. Ensuring that the family system starts to recover with the person whenever possible is helpful. And it's also important to focus on the person's strengths. Too often I've seen assessments end up being sort of a battering session for people. What have you been abusing? What negative consequences has this had? How do you expect to fulfill your goals? How is that working for you? Well, it's not. The person walks out of the assessment, feeling worse than when they walked in. While that might be an effective motivator for some, for most, it just overwhelms their coping skills and everything else. They feel hopeless and helpless, and they go out, start to use, and don't return to treatment. It's important to identify the problems. Those are motivators. But it's also important to help the person identify their strengths. They have done the best they could do with the tools they had at the time up until now. They don't lack will. They don't lack morality. They lack the tools to deal with life on life's terms. It's up to us to help them look at how they've survived in the past. What function did the drugs or alcohol serve? How did it help them survive? And how can we help them find alternate ways to survive now? Help them identify their strengths. What's good about them? What do they bring to the table? How can they use that in their recovery? If they're a good parent, awesome. Maybe they come in and they say, I had an alcoholic, abusive family when I was growing up, and I refuse to let that happen again. And I do this, that, and the other with my family. Great. If they're on the right track, then have them use those same skills to reparent themselves. So by identifying strengths that the person already has, they feel like they've got a leg to stand on, and it's not like trying to learn how to live completely all over again. During assessment, you want to gather information. Determine the client's readiness for change. If you get into a yes-but pattern, you know the person is not ready to change yet. Identify problem areas, diagnoses, disabilities, and strengths or abilities. While the person may not yet be ready to work on their drinking, they may be ready to work on their depression or on their relationship or on something else. If you can engage them in working on some problem, improvement in one area will probably lead to improvements in other areas, but either way, you're establishing rapport and you're giving yourself a greater period of time to help motivate them in all of their other areas that need to be addressed. Finally, you want to make sure that you cover all the areas to match this person to the appropriate treatment services. And that's not just what's your diagnosis and how bad is it. That's what's your diagnosis, how bad is it, what works for you, what hasn't worked for you, and what special needs might you have. If there are barriers to a person entering residential treatment or staying in residential treatment, it needs to be addressed. If there are issues a person has, for example, trauma issues, and they need to be with a female clinician, that needs to be addressed. If the person is gay, lesbian, bisexual, or transgender, that may need to be addressed in whatever facility that they will be being placed in. Discuss with them their treatment options, if they have any. Now, again, sometimes you're in a situation where you're doing an assessment for the court or for some other body that dictates that if they score a certain level, they will go to residential treatment. There's no clinical judgment involved. Well, then your hands are tied. But if you have the option to offer them level A of treatment, we'll say residential, and they refuse, but they're willing to go to intensive outpatient, then do everything you can to help make them successful in intensive outpatient. Don't just give them enough rope to hang themselves, as they say. Let them prove you wrong. Find joy when they prove you wrong and they are able to sustain sobriety at a lower level of care. That shows their strength. Now, the person-centered assessment we've talked about already a little bit focuses on finding out what the client wants. It focuses on what works for the client and what doesn't work, what the client wants to change, and how he or she thinks change will occur. Are they expecting change to happen overnight? Are they expecting everyone around them to change because they're right and everybody else is wrong? What are they expecting to happen? In the process of that, you can come to mutually agreeable goals on what will happen and how it will happen. Assessment information, as always, needs to include demographic and historical information, identification of established or probable diagnoses and associated impairments. Now remember, if someone is less than 30 days clean and sober, you're probably going to want to only provide a provisional or tentative diagnosis, because as they have the chemicals leave their system and as their brain chemistry settles out, their presentation may change dramatically. So hold off if you can making any really concrete diagnoses until somebody has at least 30 days clean and sober. Identify strengths and problem areas. If you can, for each problem area, identify at least one or two strengths. So for example, if they have an addiction problem, they drink when they get stressed out, what other positive things do they do when they get stressed out? How else do they handle stress? Or if they don't do anything else now, how did they used to handle stress? And if they didn't ever do anything else, how do they see other people positively handle stress? And yeah, you may get down to that final level, but you want to identify strengths that hopefully they have, or strengths that they see in other people that they want to have and they believe they can have. Once you determine the severity of their co-occurring disorders, you will be able to make a more concrete determination of the best level of care for them. When talking about the substance abuse aspect of it, you want to talk about past episodes. Don't romanticize the past episodes. Don't let the person get into telling you stories, old war stories, whatever. That won't work. We don't want to reinforce the drug using behavior. But you do want to ask them, when did you start? How often do you use? And look at patterns. Some people like to do charts of periods of sobriety, periods of use, charting each time whether the use got longer or more intense to see how the disease progresses and or if there are any precipitating factors that make the binges or the use worse. You also want to tie it into any of their mental health symptoms. Now again, a lot of mental health symptoms can be precipitated by alcohol and or drug use or withdrawal. Make them aware of this. Yeah, you're depressed. I would expect you to feel depressed because you've been using cocaine for 7 days straight. You're crashing hard. So these are the things that you need to illuminate for them. But it also provides hope that once they get clean, they'll start feeling better. Don't dismiss them, though, and say, yeah, I would expect that you'd be feeling depressed right now. That'll go away, and leave it at that. Let them know, reassure them that you'll come back and talk about the depression or the anxiety or whatever again each week and make sure it's getting better. And if it's not, then you'll take further steps in order to help them address that issue. People's current level of impairment is determined by assessing functional capabilities and deficits. You can use the ASAM PPC-2, which is probably the most common because it's a quick and dirty assessment. Or you can use the locus, which is a much more comprehensive assessment, and we go over that in depth in part 2 of this series. Either way, it provides you, again, an objective rating scale in order to support your decision for placement. The baseline level of impairment needs to be determined by identifying periods of extended abstinence and mental health stability greater than 30 days. Some of your clients won't have this. So they're going to be obviously on the more severe end of needing treatment services. Ask yourself, can this person live independently? Now, living independently and living and functioning well are two completely different things. Can they live independently, feed themselves, bathe themselves, dress themselves, and not cause themselves any harm? That's living independently. And you can work up from there on quality of life scale. Is the client capable of supporting himself financially? Can they pay their bills? Can they keep the lights on? If not, that identifies another issue that needs to be addressed, because we know that people who aren't eating and who aren't getting proper rest and medical care are going to have a much greater problem with sustaining recovery. Can the client engage in reasonable social relationships? That doesn't mean they have to have 15 best friends. But, as we said before, recovery can't be done alone. I don't personally think it's possible that someone can recover all by themselves. So can they form a meaningful relationship with at least one other adult? And what's the client's level of intelligence? Now, this doesn't mean that dumber people are going to have more of a problem with something and that smarter people are going to be better off. But it does affect how you tailor their treatment. As I stated earlier, a lot of my clients, when I was working in community mental health, could not read. Some could not write or read. So putting them in a situation, putting them in a setting where they had to read their big book every day and complete paperwork for homework between meetings and between groups was not productive. It was actually counterproductive. So make sure you're focusing not only on the mental health and substance abuse issues, but on how a client can function in a certain program. What accommodations can be made? If the client cannot read or write, what can you do? It doesn't necessarily mean they can't go into program X, but it means that reasonable accommodations need to be made. And finally, assessment isn't just a one-time when you're admitted sort of thing. Reassessments should be done at least quarterly, and in early recovery I find it helpful to do a mini reassessment every 30 days. When you're trying to decide on the use of placement instruments, like I said earlier, you can use the locus or the ASAM. The locus looks at the risk of harm, comorbidity, recovery support and stress, treatment attitude and engagement, and treatment history. The ASAM focuses a whole lot more just on the substance abuse. It looks at acute intoxication and or withdrawal, biomedical conditions and complications, emotional or cognitive conditions and complications, readiness to change, relapse potential, and the recovery environment. Obviously, in a substance abuse program, an ASAM will fit, but in a mental health program, a locus will probably be a better choice. Now, I'm briefly going to review the current stages of change. This should be old hat to most of you. Basically, there are 5 stages, and you don't go through them like walking upstairs. People tend to vacillate back and forth, 2 steps up and 1 step back, and sometimes 1 step up and 2 steps back. We'll talk about that in a minute. But you start out in precontemplation. They don't think they've got a problem. And try to convince them that they do, you're going to be working an uphill battle. Contemplation, they're starting to admit that, yeah, they drink too much, but they still don't need your help. You know, I might start thinking about change if things get worse, but I've still got it under control. Once they enter the preparation or determination stage, they know they've got a problem, and they're getting ready to change, but they're not quite ready to give it up. You've got to remember that in addictions, the alcohol, the drug, has served as an escape, and it has become sort of like the best friend of the people who are using it. It doesn't judge them, and it always makes the pain go away. Sometimes it's also associated with people who like them or pretend to like them. So the drug or alcohol use can seem to have positive benefits that they're not ready to get rid of yet. Once they move into action, they're ready to change. Something has changed in their life where using is more costly than not using. The benefits to using have started to disappear. Once they get into maintenance, they're stable, and they need to maintain that stability. Now, you'll notice on here relapse is not listed, because relapse is not a necessary part of recovery. It happens, and it happens a lot. But how much of a relapse or a slip occurs is dependent on the person. If they can identify their stinking thinking when it starts to come back, if they have a sponsor or they have a significant other or they have the personal insight to recognize when they're getting into dangerous situations, they can prevent that relapse from happening. Now, I said that sometimes it's 1 step forward and 2 steps back. And that generally occurs when you scare somebody. If they come into treatment and they're thinking about being willing to take a step, or even if they're willing to take a step, and you push them too far too fast, or they go too far too fast, they're like, all of a sudden they're gung-ho and rah-rah, and they're going to get through the big book in 30 days, and then they hit stuff. And we use that term kind of liberally. And they're like, oh, crap, I can't deal with this. They need a drink. Their coping skills are overwhelmed. They cannot tolerate being clean and sober and they regress. Now, whether they regress far enough to leave treatment and go out and use, or whether they fall back into precontemplation or contemplation and start trying to rationalize what they've been doing and minimize their behaviors. Depends on the person and depends on the situation. But do be aware. And it could be something as simple as they're in treatment, they're doing the next right thing, and all of a sudden they get served with papers terminating their parental rights. Nothing that you did, nothing that treatment did, nothing that they did in treatment. But it's a consequence of their actions that's coming up to bite them in the butt right now. And that pushes them into this state of, I don't give a flip about anything, because even when I'm doing the next right thing, bad things happen. As clinicians, it's important, if we can, to help people put this into perspective, pull themselves up by their bootstraps, and start moving on in order to overcome the obstacles that have been put in their path. There are certain special populations that you're going to work with. Criminal justice, women, children, and the elderly are the most common ones that we identify. When it comes to working with the elderly, as I said before, there are certain cultural considerations that we need to be aware of when we're working with somebody who is older, and be cognizant and respectful of their boundaries. But they also have different motivations. Their physical health, loss of independence, financial security, all play into motivating them. That's one of the things that a lot of older people really start to perseverate on as they start to see their friends pass on and they start to see some of their faculties decline. You can harness that, point out how their use is negatively impacting their ability to remain independent, and work with them from that perspective. With the elderly patients, it's also important to point out how the alcohol or drugs that they're using interact with any medications they may be on. Elderly people tend to clear drugs from their liver a lot more slowly than your average 18 to 45-year-old person. So if they're taking benzos or other medications, it's going to take a lot less, and they could build up a toxic level in their liver. Likewise, the medications that they're already taking for heart disease or blood pressure or glaucoma or whatever probably interact on some level with any alcohol or drugs that they're taking. So it's important to work all this in order to increase their motivation and help them become aware of their own safety. As people go through these life transitions, alcohol and drug abuse becomes more risky when they hit midlife, when all the kids move out, when their spouse dies. Major life transitions make a person more vulnerable to abusing alcohol or other substances. Other things that you might consider looking at are menopause, approaching retirement, or the death or illness of a child or spouse. All of these things really tax a person's coping skills. According to the best practices, every 60-year-old should be screened for alcohol and prescription drug abuse as part of their regular physical. I don't think that happens very often, but it's good practice to do a quick screening. With regard to confidentiality and substance abuse, you have more tightly controlled laws than just HIPAA. The federal regulations 42 and 45 CFR and the federal standards for privacy of individually identifiable health information govern what you can and can't say. This is tricky when you're dealing with adolescents. When you're dealing with adolescents, you often have parents who want to know this, want to know that, want to know what they said. You also may be dealing with an adolescent who hasn't told their parents. And in order to confirm information, you might want to talk to their parents or their principal or their teachers or something. But without their consent, you can't breach their confidentiality. There are only a few exceptions to this. If you talk to someone without revealing that the client has a substance use disorder, if the information is ordered by the court, not by an attorney, but by the court, a judge, after a hearing, in the event of a medical emergency, if anything you say is included in information regarding crimes on the program premises or against program personnel, or is information shared with an outside agency that provides service. So, for example, if you were referring them over to the local runaway shelter so they could stay there, it's advisable, strongly advisable, to get a release of information to share that with the runaway shelter. And I would do that as a matter of practice anyway. But that is one exception to the current federal standards and guidelines. Qualities of an effective assessment report. Identify the severity of the substance use disorder. Identify factors that contribute to or are related to the substance use disorder. Again, include strengths here. Okay, what makes you drink? Fine. But what are you doing when you're not drinking? Because there's got to be some time during the 24 hours in a day that you're not drinking. So what are you doing? Let's do that more often. Sleep? Okay. Work? Okay. Clean the house? Whatever it is, if you're not using and doing whatever it is, then do more of whatever it is. An assessment report identifies a corrective plan of action. It details an interim plan that ensures that the treatment plan is implemented and monitored to its conclusion. So if you're doing an assessment and referring someone on to a therapist, which again, a lot of times doesn't happen in community mental health, the person who screens, assesses, and treats is often the same person. In the event your agency is different, the assessment needs to lay out what course of action is going to happen between now and when Jim Bob meets his therapist. And it needs to detail what the therapist is going to do. Who's responsible for what and when it's going to happen. Finally, it needs to describe how resources and services of multiple agencies are coordinated and integrated. Hopefully, a lot of this will be stated in your interagency memorandum of understanding. But it's always good to have it documented in the treatment plan. Who is going to be the contact person on the multidisciplinary treatment team? Who is your contact at the case management department? Who is your contact at Voc Rehab? Who is your contact at the hospital or the doctor's office? Have all of the players identified and the main coordinating player highlighted, and make sure everybody has phone numbers and dates and everything else, so you know that this treatment plan is being followed in a timely manner. Empathic detachment is something that they teach you in Counseling 101, and it can't really be taught if you don't have empathy to begin with. But if you're in the profession, we're going to assume that you have some level of empathy. The challenge is to maintain empathy for the client if they don't seem to fit into your expectations. I remember working with a client that was referred by the Department of Children and Families, and I think the child was like 18 months old by then, but it had already been to the hospital twice with skull fractures. And she was claiming she didn't know how it happened, and, you know, obviously she was being referred for mental health and substance abuse evaluation. But the fact that this mother did not fit my conception of what a good mother was, and quite honestly, I really had to work at being empathic towards her situation, because it was hard for me to like her, since she was not able or willing to protect her child. Clearly, I was able to refer this client out, and thankfully I was only doing the screening, because I think I would have had a difficult time conducting an accurate, comprehensive assessment. And these are things you need to be aware of. You need to be aware when you've got issues, you've got blind spots, you've got whatever, that will make it difficult for you to give a client an accurate assessment. Now, would I have made a proper diagnosis by DSM-IV criteria? Yeah. But I don't think I would have been able to effectively work with the client on a 6 or 8 or 10 month basis. And so then it's also important, again, if you are the one who typically screens, assesses, and treats, if you conduct an assessment and you know that it's one of those few clients that for some reason you're going to have difficulty working with, you either need to seek supervision immediately and or refer out, because you're going to have difficulty being effective. When you're using instruments, and in most community mental health situations, you actually use fewer instruments than are probably needed. But when you are using instruments, you need to make sure that you're using them correctly. You're following directions, you're using them for the purpose that they were intended, and you're using them on the population on which they were normed. You don't want to use an instrument that was normed on white adult males on Hispanic adolescent females. It's not probably going to give you effective data. Make sure you know what you're using. Make sure you know how to interpret it. Okay, so they received a 75 on this scale and an 85 on this scale and a 30 on this scale. Well, does that mean that on those first 2 scales they're doing pretty well and not so good on the last one, or what? Depending on your instrument and depending on your cutoff scores, 75 may not reach the threshold for cutoff on some instruments. So know what these numbers mean, because without meaning to you, the numbers are meaningless in your assessment. And assessment instruments need to be able to have some test-retest reliability and the ability to measure meaningful behavioral and attitude changes over time. Theoretically, if a person takes an inventory that assesses their attitudes towards substance use and abuse, and they show favorable attitudes and substance abuse tendencies, then after 6 months of treatment, we would expect that their score would change. If it doesn't, you're either going to have to look at your treatment style or the reliability and validity of the test. Tests should include the author's description of how the test should be administered, scored, and interpreted, the aim of the test, for whom the test is and is not appropriate, whether it can be self-administered or it must be given by an examiner. This is one of the most frequently fudged things. A lot of times we just want to hand them papers to fill out while they're in the waiting room. There's a real strong pull to try to get some of that paperwork done before they come into your office. But the reliability and validity of some assessment instruments are going to be negatively impacted if they do paper pencil when it's something that they're supposed to respond to and it's supposed to be read to them. Reliability and validity and appropriateness are two of your key factors no matter what population you're testing on. You want to make sure that you're using it on the right population and it's a good test. But you also want to look at the setting in which the test was developed. If it was developed on college students, you're going to get much different results than if it was developed on a criminally insane population. Again, make sure it was developed and normed on your particular population. Screening for adolescents should last no more than 30 minutes. Screening for most people probably shouldn't last more than 30 minutes because in this period, you're just trying to figure out if they need further assessment. You don't want to start doing part of an assessment and then have them have to rehash everything again when they come back for their real assessment. It should focus on the person's substance use severity and core group of associated factors such as legal problems, mental health issues, functioning in their job and at school, and their living situation. There are 12 steps in the assessment process. In order to complete a good assessment, you need to obtain a more detailed chronological history of past symptoms, diagnosis, treatment, and impairment. And get a sense, if you can, about what life was like, what any impairments were like before the substance use started, after the substance use started, and if there's been any period of extended sobriety, what it's been like during those periods, because those are very distinct periods of functioning. Obtain a more detailed list of strengths, supports, limitations, skill deficits, and any barriers that might need to be overcome. And determine the stage of change for each problem. Like I said earlier, somebody may be willing to work on their relationship or their depression or some other problem, but not ready to work on their substance abuse yet. So for each problem, identify the person's readiness for change. Obviously, you're going to be more effective if you start working on the problems for which the person's ready to work. So your 12 specific steps are to engage the client, gather additional information as allowed by law, screen for and detect co-occurring disorders, determine their quadrant and locus of responsibility. That means, are they high substance abuse, high mental health impairment, low substance abuse, low mental health impairment, or some combination of high and low. Determine the level of care required. Determine their diagnosis. Determine their disability and functional impairment. You can have the same diagnosis on 3 different people and have 3 different levels of disability and functional impairment. Identify strengths and supports. Cultural and linguistic needs and supports. And this includes sign language. If you're going to need to call for an interpreter, it's best to identify it now. Identify problem domains. Determine the person's stage of change for each problem. And work together to develop a collaborative treatment plan for each problem. When you're assessing, it's easy to focus on the mental health diagnosis or the substance abuse diagnosis. But we need to remember that a person doesn't live in a vacuum. And as Maslow stated in his hierarchy, people need to have their basic needs met first before they can even begin to develop relationships and self-esteem and self-efficacy. So look at the recovery environment. Do they have food? Do they have safe housing? Do they have sober social supports? Look at their medical, addictive, and psychiatric comorbidity. What other stuff do they have going on that may impact them? Are they on medications for another issue that may complicate their treatment? Do you need to work with a multidisciplinary treatment team in order to most effectively help this person? Look at their risk of harm and their ability and willingness to stay clean. And these are all very distinct things. Their risk of harm, either through suicide or homicide, or simply not being able to care for themselves and stay clean and sober. Their ability to stay clean is very often much different than their willingness to stay clean. When people are in the action stage of change, they may be very willing to stay clean and sober, but they may not have the ability to do it in an outpatient treatment setting. So this is where we need to help them develop the tools so they have the abilities. So this last one is really packed full of stuff. Are they safe? Are they willing to stay clean? Are they motivated? And do they have the ability? Once you've determined all those things, you want to look at whether the client is willing to participate in treatment and how much awareness they have of really what the problem is. I mean, the big scope, where it came from, where it's going, how it's impacting them. And again, a willingness to participate in treatment may be very different than a willingness to stop using. Some people may be willing to stop drinking, but they don't want to go to those places in the closet where they've got all those skeletons. Their functional status measures the degree to which they're, functioning. Can they fulfill social responsibilities, interact with others, bathe themselves, feed themselves? Then look at treatment and recovery history, because they probably tried to stop. Most people don't come to treatment before they've tried to stop on their own. So ask them about prior attempts to stop, what's helped, what hasn't, what caused their relapse, what brought them here today. This will give you an idea about what their strengths are and what strengths they have that you can bolster. It's better to start with something they have than try to reinvent the wheel. And then you want to develop treatment outcomes for individuals with multiple problems. Treatment outcomes are your goal statements. Try to make them as positive as possible. Not, John will stop drinking. Well, okay. Yeah, but what's he going to do instead? That's one of the questions I repeatedly ask my clients when I'm working with them. All right, you can tell me until the cows come home all the things that you're not going to do, but that doesn't help me understand how you're going to stay clean and sober. What are you going to do? So your goal statements need to be positive and proactive. Understanding your client's mental health symptoms and impairments that persist during periods of abstinence of 30 days or more is useful in understanding how they cope when even the acute effects of substance use are not present. Now, what does that mean? That means if the person can remember a period when they've been clean for more than 30 days, you can start to identify what some of their inherent coping skills are and how they use them, how they confront or run away from stress and adversity. If they don't have 30 days or more clean, it's really still going to be hard to assess whether they've got any sort of organic depression that's laying in there, or whether it's all due to substance use, intoxication, or withdrawal, and how they would really cope when they're clean when faced with adversity. Doesn't mean you can't figure these things out, but it may not be able to be done accurately at the initial assessment. Warning signs that may emerge in conversation that tell you this person may have a substance abuse problem include excessively worrying about whether prescription psychoactive drugs are really working to alleviate their complaints. If somebody constantly wants more Xanax or needs stronger painkillers or whatever, they may be evidencing drug tolerance. Warning sign. If they start telling you detailed knowledge about specific drugs and attaching great significance to its effectiveness and its personal impact, clearly indicating that they want you to prescribe it or they think they need to be back on it, it's a warning sign. If their life revolves around when they're going to take their next pill, it's a warning sign. And if they continue to use refill requests when the physical or psychological condition that the drug was originally prescribed for is gone, it's a warning sign. So, here's your sign. These are all things that may come up in normal mental health assessments that need to make you kind of stand up and take a closer look at whether there's a co-occurring substance disorder. Now, adolescents are their own unique beings. They're not children anymore, but they also are not just little grown-ups. So when assessing an adolescent, we need to be a little bit more flexible in some of our definitions. Adolescents may define family in non-traditional ways. As our culture has evolved, it seems that even adults may define family in non-traditional ways. So it's important to recognize that it's not always mom, dad, baby sister, the dog, whatever. A person's family is the person or persons that provide the youth or the client support, encouragement, love, affection. That's family. Now, if that is their group of friends in the people they hang out with and they live on the street, that's family. If that's, Uncle Bob and Aunt Jane, or if that's mom and dad, we need to ask them, who's your family? Who do you consider to be there for you? Most everybody has somebody that's there for them. And it's also important to recognize that substance abuse may just be a symptom of a much deeper problem. Yeah, the adolescent may be abusing substances. And this can be said about adults too. There may be a history of abuse. There may be current abuse. There may be a psychiatric issue. Substance abuse may be a symptom. The person may be self-medicating. So it's important to look at that too. Just like when you start to treat the mental health symptoms, some of the substance abuse symptoms may start to subside Just like when you start to treat the substance abuse, some of the mental health symptoms may subside. So you can't really get a good anchor on what's really there until you've had the person in treatment for a while, and you can start to see what they're like when they're clean and sober. When a program that screens, assesses, or treats adolescents asks a school, doctor, or parent to verify information, it's making a client-identifying disclosure that the adolescent has sought services. Federal regulations generally do not allow this kind of disclosure unless the adolescent consents. Now, to this point, we've been talking about addictions being drugs or alcohol. But we know that addictions are behavioral too. Compulsive eating, compulsive spending, internet addiction, compulsive sex, gambling, abuse of over-the-counter medications or prescribed medications. There are a bunch of different types of addictions. And it's vital in treatment to make sure that somebody's not just switching addictions. Yeah, they may not be drinking anymore, but if they're compulsively eating or compulsively having sex, they're not sober. They're simply not drinking anymore. That's not recovery. That's not improving their quality of life. Critical components in the assessment process include getting to know the person, their complex individual needs, not relying on tools alone for a comprehensive assessment, not allowing preconceptions to interfere with learning about what the client really needs, always making every effort to contact all involved parties as allowed by law, being familiar with the diagnostic criteria for Axis 1 and 2 disorders, being familiar with Axis 3 disorders, that's physical disorders, that mimic mental health problems, hyperthyroid, hypothyroid, diabetes. There's a lot of things out there that may be causing mental health type symptoms. And Axis 4 problems or psychosocial problems exacerbating the issue. Domestic violence, stress at the office, current loss of a loved one or a pet or whatever. It's important to know the process for referring clients for mental health case management services or for collaborating with mental health treatment providers. Now, in many instances, you're not going to be able to access case management because your client is not going to be ill enough, as they say, for managed care to cover it. That doesn't mean that they don't need case management, and it's useful if you can work with your agency to develop a system or a network to provide something similar to case management for those people who don't quite qualify for reimbursable case management. And often this can be done through the use of a volunteer corps or interns. It requires a little creativity and a fair amount of training, but once you get the program up and running, it's extremely beneficial not only at providing the services, but reducing relapse and utilization of your primary service providers. Don't be afraid to admit when you don't know something, either to the client or yourself. If you don't know, don't guess. Seek consultation. And remember that co-occurring disorders are the rule, not the exception. I think I've said that like 4 times now, so I know you're tired of hearing it.